Everyone. It's my pleasure to speak with you now on the quantitation of aortic regurgitation. I have no conflicts of interest, but do want to thank Dr. Roberta Lang for sharing selected slides that I'm using in this presentation. So the knowledge about aortic regurgitation has actually been around for quite a while. One of the first descriptions occurred in 1705 when the English anatomist Cowper described the occurrence of stiffening and thickening of the aortic valves, so they quote unquote did not apply adequately to one another. So that was one of the first descriptions of a non-functioning regurgitant aortic valve. We've come a long way since then, and now we've recognized that there are lots and lots of causes of aortic regurgitation, and they're divided into the graph that I have shown here. And this is divided into those causes that occur acutely and those that present chronically. In both cases, in the acute and the chronic situations, the aortic regurgitation may be due either to a valve alteration or to mixed valve and aortic root pathology. So when we look at the acute presentations, the predominantly valvular causes include infective endocarditis, acute prosthetic valve dysfunction, a ruptured fenestration, blunt chest trauma, or as a complication of procedures such as radiofrequency catheter ablation. For those that are acute and due to mixed valvular or aortic root alteration include aortic dissection, paravalvular leaks post-TAVR, and post-balloon valvuloplasty. In the chronic situation, valvular lesions that often lead to regurgitant aortic valves include rheumatic fever, myxomatous degeneration, chest radiation, systemic lupus erythematosus, rheumatoid arthritis, Whipple's disease, Takayasu's arteritis, drug-induced valvulopathy, and tumors. Those that are due to the aortic root plus minus the aortic valve include aortic aneurysms, congenitally abnormal aortic valves such as unicuspid, bicuspid, or quadricuspid valves, which are often associated with aortic aneurysms. Connective tissue disorders such as Marfan's, Ehlers-Danlos, osteogenesis imperfecta. Again, oftentimes those are also associated with aortic aneurysms. Behçet's disease, Reiter's syndrome, aortitis such as syphilis or giant cell arteritis, psoriatic arthritis, ankylosing spondylitis, or Crohn's disease. So there is a way to classify the different mechanisms of aortic regurgitation. And I borrowed this diagram from the ASE Native Valve Regurgitation Guidelines that was published in 2017. And I encourage you to look at that guideline document for a full discussion on how to assess and quantify native valve regurgitation. So basically, with the classification of AR mechanisms, they're divided into type 1, type 2, and type 3. Type 1 lesions are due to normal cusp motion with aortic dilatation or cusp perforation. So a type 1A is due to enlargement at the level of the sinotubular junction and the ascending aorta. Type 1B is dilatation at the sinotubular junction and the sinuses of Valsalva. A type 1C is at the dilatation at the annulus. A type 1D is a cusp perforation. Then a type 2 is cusp prolapse, and a type 3 is cusp restriction. So here's some examples of some of these different types. So here we have an example of an aorta that's dilated at the sinotubular junction as well as the ascending aorta, resulting in severe regurgitation. And here we have a type B at the sinotubular junction and the ascending aorta, again causing severe regurgitation. Here's a type C where there's dilatation of the ventricular arterial junction or the annulus. And then here is an example of cusp perforation or a type 1D. A type 2 is prolapse of a cusp as shown here. And here's a type 3, which is a restricted cusp leading to poor coaptation and thus aortic regurgitation. So let's look at a few more examples. Here's another one that's a type 3, which is a bicuspid aortic valve. You see the doming of the valve here and that fish mouth appearance when the valve opens. There are other causes that we can see not just with echo, but also with cardiac magnetic resonance imaging. Here's an example of a bicuspid valve as was shown in the last echo. Here's a mass on the aortic valve that resulted in poor coaptation and regurgitation. Here's an example of an aortic aneurysm and an example of an aortic dissection. Here's a couple more examples. So here's a patient actually that has a unicuspid aortic valve resulting in regurgitation. So this is another type 3 because it's a restrictive lesion. And here's what the valve looked like in the operating room. Here's an example of a rheumatic valve. Notice that the thickening is predominantly at the tips of the leaflets, and that results in poor coaptation because of all that thickening and scarring at the leaflet tips. And in this case, there's regurgitation in the center of the valve. And here's what that valve looked like when it was removed in the operating room. Here's a couple more examples. This is a type 1D of a patient with infective endocarditis resulting in prolapse of a leaflet, resulting in severe regurgitation. This is actually a cusp perforation, and they would give a clue for that because look at how localized that jet of regurgitation is right over, this is a transesophageal echo, so this would be the left coronary cusp. See how localized it is over that left coronary cusp, suggesting that there's a perforation there. And when we look at that same cusp after it was removed in the operating room, you see a perforation here in the center of the valve that corresponds exactly to where that jet of aortic regurgitation originated from. So let's talk a little bit now about the differences between acute and chronic aortic regurgitation. Remember that in chronic regurgitation, the adaptation of the left ventricle to the regurgitation happens slowly over time. And what happens is that the ventricle dilates and there is the formation of hypertrophy in an eccentric fashion. So the combination of the dilated ventricle plus the eccentric hypertrophy allow the ventricle to adapt to the volume overload associated with the regurgitation. This allows an individual to withstand even severe regurgitation for quite a long time. However, in the case of acute aortic regurgitation, the ventricle has not had any time to adapt. Therefore, the heart is seeing a massive amount of extra blood in a usually small LV chamber that is not adapted to volume overload. And that's why individuals who develop acute severe aortic regurgitation can develop very severe life-threatening heart failure. So here's an example of a 69-year-old man admitted for sudden onset of severe shortness of breath with the production of pink frothy sputum. You see on his echo that he has severe aortic regurgitation. And so what are some of the findings that we see on echo when we have severe aortic regurgitation? Well, two of the findings that we see are early diastolic closure of the mitral valve and early diastolic opening of the aortic valve. And what happens here is here's the pressure tracing of your left ventricle. And because of a non-compliant, unadapted left ventricle, when the massive amount of blood in diastole goes into that ventricle, there's a very rapid rise in pressure in the left ventricle because, again, it's not adapted to that volume overload. This then results in early closure of the mitral valve and diastolic opening of the aortic valve. And this is what it looks like on the echo. So here is an M-mode tracing showing the mitral valve opening. And as you recall from a normal M-mode tracing, the mitral valve should be open and then close right around the R wave of the EKG. And you see that the mitral valve here closed very, very early, much before that R wave. We can also see the same thing on pulse Doppler. So here's pulse Doppler of the mitral valve showing that E wave. And we should have an A wave and the end of the mitral Doppler signal at the R wave. And you see here that we have no signal from about the mid portion, mid diastole to the end of diastole, again suggesting that the mitral valve has closed early. So this is an important finding to recognize and is a sign of severe acute aortic regurgitation. Also note on the M-mode is this fluttering here, which is reflective of that jet of aortic regurgitation hitting the anterior leaflet of the mitral valve. Diastolic opening of the aortic valve is something that we can see well on an M-mode tracing. Here's two different M-mode tracings, again showing. Here's the systolic portion of the aortic valve opening, which looks normal, but you see here that there's also opening of that aortic valve in diastole, again, due to that sharp rise in diastolic pressure in the left ventricle. So make sure you recognize both of these findings. So now how do we grade the severity of chronic aortic regurgitation? So we're going to look at structural parameters, qualitative Doppler parameters, semi-quantitative Doppler parameters, and quantitative echo-Doppler parameters. I again urge you to look at the native valve regurgitation document put out by ASE, published in 2017, because it gives a very nice overview of all the quantitative parameters that I'm going to be discussing with you. So if you have questions about that, I refer you back to this document. So the first step in evaluating the severity of chronic AR is to look at the structure of the heart. We want to see, is the left ventricle dilated? Is the ejection fraction normal? And we also want to look at the aortic valve itself. Do the leaflets look normal? Do they look abnormal? So taking a very good look at the 2D findings before actually turning on any Doppler examination. And in the case of mild regurgitation, oftentimes the valve looks normal or only mildly abnormal. LV size in general is usually normal. As opposed to in severe regurgitation, where the aortic valve may look very, very abnormal and the left ventricle is usually dilated. Now, of course, this is in the chronic setting. If the valve looks abnormal in the acute setting, the left ventricle may look perfectly normal. So let's talk about first the qualitative Doppler parameters to assess the severity of chronic AR, and those are included in this list, including jet width in the LVOT, flow convergence, jet density that we measure by CW Doppler, jet deceleration rate, which is the pressure half-time measured by CW, and then looking at diastolic flow reversal in the descending aorta with PW Doppler. So let's first talk about the jet width divided by the LVOT diameter. That's a measurement that we make on the parasternal long axis view using a zoomed mode. We want to align the jet to optimize the visualization of the vena contraction. So that may be different than what we do for PISA. We want to measure the jet in the LVOT about 1 centimeter below the vena contracta. So we're not measuring at the vena contracta, we're actually measuring below it, as shown in this diagram. in this diagram right here where these red arrows are, that's where we want to measure the diameter of the jet, not at the vena contracta, which is right here. Because we want to measure it at the same spot where we're going to measure the LVOT diameter, which is where this arrow is here. So then we're going to measure the jet width and then divide that by the LVOT diameter. The advantages here is that it's relatively simple, it's the sensitive screen for aortic regurgitation, and is a rapid qualitative assessment. Disadvantages is that it underestimates the regurgitation when you have eccentric jets and may overestimate it in central jets. And that's because the jet may expand unpredictably below the orifice. And it's also affected by the size of the LVOT. So if your LVOT is big, then it may result in a smaller ratio, and the opposite if it's small. Other ways that we could measure the severity in a qualitative standpoint is to do proximal flow convergence. So here we're going to align our beam with the flow of insination. We want to be in the zoomed view. We want to turn off the variance. And then just like doing PISA for the mitral valve, you want to shift your baseline in the direction of the jet. And then we want to measure the radius from the point of aliasing to the vena contracta, as is shown in this arrow over here. And this provides a rapid qualitative assessment. The disadvantages is that you can't do this with multiple jets, eccentric or constrained jets, those with a non-hemispheric PISA, or timing in early diastole. We can also look at the density of the regurgitant jet. We want to do this by, again, aligning our insination beam with flow and adjust our overall gain in order to adequately see the signal. The advantages here is that it's simple, and faint or incomplete jets are compatible with milder trace AR. Disadvantages is that it's qualitative. Perfectly central jets may appear denser than eccentric jets, so may be hard to differentiate. And there's a lot of overlap between moderate and severe AR. What about pressure half time or deceleration rate? Again, we want to align our insination beam with flow. This is usually best from apical windows. In eccentric jets, it may be best from the peristernal window. It just depends on the direction of your jet, and you may use color Doppler to help you. The advantage here is that it's simple. It's a specific sign of pressure elevation between the aorta and the LV. Like everything, however, there are disadvantages. It's qualitative. Poor alignment of the Doppler beam may result in a lower pressure half time. And importantly, it's also affected by changes that modify the LV and the AO pressure gradient. For example, if the pressure half time is short, it may imply that the AR is severe. Alternatively, it may suggest that there's elevated LV filling pressures, and that is what's causing the pressures to equilibrate quickly, not that the fact that the AR is severe. So like everything, we have to keep the advantages and the disadvantages in mind of all our techniques. We can also look for holodiastolic flow reversal in the proximal descending aorta. We want to align our insination beam with flow and place a pulsed wave sample volume in the proximal descending or the abdominal aorta. The advantages here is that it is a very simple supportive sign of severe AR, and it is more specific if we see flow reversal in the abdominal aorta. Disadvantages is it depends on the compliance of the aorta, and thus it is less reliable in older individuals. Brief flow reversal is normal, so we want to look for the holodiastolic flow reversal as shown in the example here. And this may be seen in other conditions and may not be seen in the presence of acute AR. So don't discount the presence of severe aortic regurgitation if you don't see this finding, particularly if we're dealing with acute situations. So here's just an example of a patient that has severe aortic regurgitation, and you can see the nice pulsed wave signal of the whole diastolic flow reversal in the aorta here. So how do we use this to grade? So these are all of our qualitative parameters shown here that we had just looked at. And if the AR is severe, our jet width in the LVOT is usually small. Flow convergence is none or very small. Jet density is incomplete or faint. Our pressure halftime is over 500 milliseconds. And diastolic reversal in the aorta is either brief or early diastolic. This is in opposed to the severe case where the jet width is large in central jets but can be variable in eccentric jets. Flow convergence is large. The CW jet density is dense. Pressure halftime is steep, less than 200 milliseconds, and there's prominent holodiastolic reversal in the descending aorta. And then, of course, moderate is everything in between. So these are our semi-quantitative parameters here that we can also measure: the vena contracta width, the width to LVOT ratio, and the jet cross-sectional area divided by the LVOT cross-sectional area done in the peristernal short axis view. So let's just look at a couple of those examples. So here is the measurement of the vena contracta shown between the two red arrows. We again use our peristernal long axis view, zoom up so that you can really see that signal well. Align the jet to optimize the vena contracta imaging, and this may be different than optimization for the hemisphere, for the proximal hemisphere when we're measuring PISA. Measure the narrowest jet diameter just apical to the valve, as shown between the two red arrows. The advantages here is it's a surrogate for the regurgitant orifice size, may be used in eccentric jets, is independent of flow rate and driving pressure, and less dependent on technical factors. And it's good at identifying mild or severe AR, less useful for moderate. Its disadvantages is the presence of multiple jets or bicuspid valves, and the convergence zone needs to be visualized. If you don't see the vena contracta, of course, it's impossible to measure it. And the direction of the jet will influence its appearance. So some creative imaging may be needed to optimize visualization of the vena contracta. We can also measure vena contracta using three-dimensional echo. And in this case, we want to align our orthogonal cropping planes along the axis of the jet. We want to choose a mid-diastolic cycle, and we want to note that non-coaxial jets or aliased flow may appear laminar, but still represent regurgitant flow. Advantages here that we can look at multiple jets of differing directions that we can measure individually. The disadvantage is that dynamic jets may be over or underestimated. And of course, it takes a little practice and expertise, not only to acquire these images, but also to know how to do the measuring. Jet area divided by LVOT area. This measurement we make on the peristernal short axis view, again using the zoom mode. We want to measure in the LVOT within 1 centimeter of the vena contracta, similar to what we did when we measured the LVOT or the jet width divided by LVOT ratio in the peristernal long axis view. Here we then measure an estimate of the orifice area and then take a ratio with the LVOT area. The advantages is it is an estimate of regurgitant orifice area. Disadvantages is direction and the shape of the jet may over or underestimate the jet area. Also, in the peristernal short axis view, if you're doing this with 2D imaging, it may be difficult to know exactly where you are and to know where exactly in the LVOT you are. So unless you use biplane imaging, that could be a little bit of a challenge as well. Using some of these semi-quantitative parameters of aortic regurgitation that's mild, in general, has a vena contracta width less than 0.3 centimeters, a jet width, LVOT width ratio of less than 25%, and the ratio of the jet cross-sectional area to the LVOT cross-sectional area less than 5%. As opposed to the severe case where the vena contracta is over 0.6 centimeters, the jet width, LVOT width ratio is greater than or equal to 65%, and the cross-sectional area ratio is greater than 60%. All right, let's move on to looking at quantitative parameters of assessing the severity of chronic regurgitation. And those include regurgitant volume, regurgitant fraction, and effective regurgitant orifice area. All right, so first let's look at the PISA method. So we talked a little bit about measuring the radius, but let's talk more about how to actually calculate the ERO and the regurgitant volume. So the first thing we need to do is to align our insonation beam with the flow, like always, lower the color Doppler baseline in the direction of the jet, and then look for the hemispheric shape to guide the best lower Nyquist limit. Then you want to use your C Doppler of regurgitant jet for the peak velocity and the VTI. This has its advantages in that it's a rapid quantitative assessment of lesion severity with measurement of the EROA and volume overload, which is the regurgitant volume. Disadvantages is the feasibility is limited by aortic valve calcifications because sometimes it makes it hard to see that PISA hemisphere. It's not valid for multiple jets. It's less accurate in eccentric jets, and very small measurement errors in measuring the radius can lead to substantial errors in measurement of the EROA. So let's go through an example of how to do this. So the PISA calculation is based on the conservation of flow. And so we know that flow on one side of the valve has to equal the flow on the other side of the valve. So flow proximal equals flow distal. Flow is calculated by area times velocity. So A1 V1 equals A2 V2. We should all be familiar with that calculation by now. So then if we plug in the numbers, so the flow on the proximal end of the valve is 2 pi r squared, with the radius being that where we measured from our hemisphere here, times the aliasing velocity, equals the EROA times the peak velocity of the AI jet. And that is this value over here. And then if we solve for the EROA, we just bring the velocity jet measurement to the denominator, and then we calculate our EROA. So let's just go through how to do that. So here we have already baseline shifted, and we're going to measure our radius, okay? And here we've already baseline shifted, and so our aliasing velocity here is 25.1 centimeters per second. And then we're going to measure the peak velocity of our AI jet. And that's 525 centimeters per second. So if we plug in all of our numbers, okay, so the 2 pi r squared times aliasing velocity equals EROA times 525. If we multiply these values together and then bring the 525 over to the denominator, we calculate an EROA of 0.22 centimeters squared. We can then use the VTI of our AI signal here. If we multiply that times the EROA, we are then able to calculate our regurgitant volume. So in this case, if we multiply the values together, we get a regurgitant volume of 65 cc's. So if you can understand this formula, if on the exam, instead of asking you to calculate the ERO, they may, or actually, if they don't ask you to calculate the ERO, but they give you the ERO and want you to calculate the regurgitant volume, or alternatively, if they give you the regurgitant volume and they want you to calculate the ERO, you can simply rearrange the equations as shown here, to calculate the value that you want. So if you're trying to calculate the ERO, it's basically the regurgitant volume divided by the regurgitant VTI. So you just have to know that equation and be able to move things around depending on what they're asking you to calculate. Now, what are the cutoff values for regurgitant volume? Mild AR is less than 30 cc's. Mild to moderate is 30 to 40 cc's. Moderate or moderate to severe is 45 to 49, and severe is greater than 60 cc's. Another way to calculate regurgitant volume is by using the fact that flow across all valves should be the same in the absence of a regurgitant lesion. Now we know we're trying to solve for aortic regurgitation, so we know that valve is going to be leaking. But if we compare it to the flow of a non-leaking valve, such as the mitral valve or the pulmonic valve, if those valves are normal, we can calculate the stroke volume across those two valves, subtract one from the other, and calculate the regurgitant volume. We can also, so here's an example of how we can do that. So in this case, we're measuring flow across the LVOT and flow across the mitral valve and comparing the two. So the calculation for stroke volume of the LVOT is the area of the LVOT times the LVOT VTI. The stroke volume across the mitral valve is the area of the mitral valve times the VTI of the mitral valve. Keep in mind that the VTI here needs to be at the annulus, not at the leaflet tips. And then we would simply subtract one stroke volume from the other. We can also use the total stroke volume from the left ventricle, assuming that there's not significant mitral regurgitation. You can take the end diastolic volume minus the end systolic volume, and that will substitute for this value here. And so the advantages here, it's quantitative, it's valid with multiple and eccentric jets, and provides both lesion severity and volume overload information. The disadvantages are that it's very difficult to measure the mitral valve annulus diameter. Therefore, if you're off in your diameter of the mitral valve annulus, your calculation of the mitral valve area is going to be way off as well. You can't use this in the setting of mitral regurgitation, and then you have to use the pulmonic valve instead. This is a very cumbersome method, needs training, and needs really good image quality. And small errors in the diameter measurements anywhere, even the LVOT or the mitral valve, can lead to substantial errors in the EROA. We can also use these numbers to calculate the regurgitant fraction, which is the ratio of the aortic regurgitation divided by the total aortic stroke volume multiplied by 100. A regurgitant fraction less than 30% is considered mild, greater than 50% is considered severe, and everything in between is considered moderate. Here are the cutoff values for chronic AR severity using the parameters that we just talked about. In the case of mild regurgitation, a regurgitant volume less than 30 mLs per beat is mild, a regurgitant fraction less than 30%, and EROA of less than 0.1 centimeters squared. On the severe side, a regurgitant volume of greater than or equal to 60, a regurgitant fraction greater than or equal to 50, or an EROA greater than or equal to 0.3 are the values for severe, and then everything in between is moderate. Here's a very nice diagram that's in the guidelines for native valve regurgitation assessment. It published in 2017 by the ASE, giving an algorithm of recommending of how to put all of these parameters together in your assessment of aortic regurgitation severity. So the first question to ask yourself is, does AR meet specific criteria for mild or severe? So if we go yes, severe, we're going to first look at these parameters. We want to look at the anatomy. Does the valve look abnormal, suggesting that severe regurgitation is reasonable? Is the vena contracta more than 0.6? For central jets, is our width of the jet divided by the LVOT more than or equal to 65%? Is there a large flow convergence? Is there a holodiastolic flow reversal in the aorta? And is the LV enlarged? If all of those are present and you're really confident to say, yes, this is severe. If you only have 2 out of the 3 criteria, it's not quite clear, then whenever possible, we want to perform more quantitative methods, such as calculating regurgitant volume, regurgitant fraction, and the effective regurgitant orifice area to be able to give us more definitive information as to what the severity is. And then similarly, if it's mild, we want to use these very same parameters. And again, if you're pretty confident, you can just call it mild. If you feel that you need more information, that's when we provide the more quantitative measures to give us more certainty on the severity of regurgitation. Like anything, there's no one parameter that gives you the best information or the only information. It is truly the need for an integrative approach to take advantage and know the limitations of each of the individual modalities. There are times, even though echo is a wonderful technique and is the first line test to assess for regurgitation severity, there are times because of technical limitations or body habitus in which the echo is not giving the information we need and our confidence in the values is low. Or it may provide discordant information. So perhaps the regurgitation by all of our quantitative techniques are mild, but the patient has severe symptoms. So there's a discordance between symptoms and the clinical picture of the patient. So when we have these uncertainties, other tests such as cardiac MRI may be useful. And here's just an example of a patient with aortic regurgitation and how the MRI can be useful to quantify regurgitation in the settings where echo is unable to do so. From a clinical perspective, why is all this important? Well, we know from historical data and looking at natural history studies of patients with asymptomatic severe AR with normal LV function, that the rate of progression to death symptoms and LV dysfunction is about, on average, 4.2% per year. What this means is that chronic aortic regurgitation generally evolves slowly with a very long asymptomatic compensated phase. However, we don't know when patients are going to become symptomatic and what kind of clinical picture they're going to have, so we need to follow them carefully. And this is a graph with a composite of 3 different natural history studies showing that after about 10 years, half or more patients will have met one of the endpoints. And we know that 30% of these endpoints occur before the onset of symptoms. So most likely they're having asymptomatic LV dysfunction. And this is where echo is really beneficial because we can pick up abnormalities that are occurring that would prompt a patient to proceed to surgical correction before symptoms and therefore hopefully prevent the onset of heart failure. Factors predictive of symptoms and or LV dysfunction based on these historical studies include end-systolic dimensions and volume and diastolic dimensions and volume and LV ejection fraction, particularly with exercise. So all of these studies have been put into the AHA-ACC practice guidelines for patients with valvular heart disease. The last full guidelines was published in 2014. There is a new revised guidelines coming sometime this year. Not sure exactly when that's going to be published, but if we were going to go by the guidelines to date, this is what the guidelines would tell us. So the indications for valve replacement include symptomatic patients, patients with LV systolic dysfunction with an ejection fraction less than 50%, or patients undergoing other cardiac surgeries. And these are all class 1 indications for patients with severe chronic aortic regurgitation. Class 2A recommendations are those with severe LV dilatation, defined as an LV systolic dimension of greater than 50 millimeters, or progressive LV dilatation, including those with an LV diastolic dimension greater than 65 millimeters if a patient is of low surgical risk. So, the key points that I feel that you should know for the echo board exam regarding aortic regurgitation is: number one, understand and recognize the different mechanisms of aortic regurgitation. Understand the hemodynamic differences and echo findings between acute and chronic AR. Know the methods to grade AR and the cutoff values for mild, moderate, and severe. Know how to perform all calculations. And anything that could be calculated, know it, because chances are they'll probably ask you about it, because calculations are an easy thing to test for. So know all those calculations back and forth. And then know the surgical indications for AVR, just to try to put this into clinical perspective. So again, I wish you the best of luck on this examination, and thank you very much for your attention.